Uh, Good morning. Today we'll have two short case discussion. One on post-burn contracture, which is a very important case for exam, and
Your audio is not audible.
Carcinoma.
Sir, your audio is
Dr.
not
Paritus
audible.
Chandra, who is a hospital, will present the case, and Professor Vipul De, who is Professor of Science Medical, will start the first case.
Hello.
Yeah, please start.
Good morning, sir. My name is Dr. Paritosh, resident Tree from Apollo Hospitals, Kolkata. Sir, my first short case is a post-burn wound contracture. So patient particulars, sir, is a female, 24 years of age, married, homemaker by occupation, residing in North 24 Parganas, and respondent, self-respondent. So she presented with chief complaint of restriction of neck movements for 8 months and difficulty in closing the mouth for 6 months. So history of present illness. My patient gives a history of stove flame burn 1 year ago while cooking, due to which she had sustained burn injury over her lower face, neck, and upper chest. She was admitted in a hospital and was treated with IV fluids, antibiotic, and regular dressing. The wound took about 4 months to heal completely and healed by scarring. After healing, she noticed that the scar tissues were getting thickened gradually, which led to progressive restriction in the movement of the neck. She complained of difficulty in closing the mouth for the last 6 months. It was also associated with difficulty in chewing food and drinking liquids and drooling of saliva from angle of the mouth. She also complains of difficulty in speech due to difficulty in closing the mouth. No history of itching over the scar, no history of blister formation in the affected burn area. So past history, she is a non-diabetic, non-hypertensive, no hypo or hyperthyroid features, no history of any surgeries in the past, and no other major ailments in the past. Personal history, she has been married for last 1.5 years. She has no children. She takes mixed diet. Bowel bladder habits are normal. Sleep appetite normal. Socio-economic status is poor, and so she is having an ongoing menstruation. So family history not significant. Treatment history: she was treated for this burn injury with IV fluids, antibiotics, and regular dressing for about 4 months. She is not on any regular medication at present. So she is not allergic to any known medications. So summary of the history: this 24-year-old female sustained stove flame burn injury 1 year back involving the lower face, neck, upper chest. She was admitted in a hospital and was treated with antibiotics and regular dressing. The wound took about 4 months to heal completely and healed by scarring. So after healing, she noticed that the scar tissues were getting thickened, which led to progressive restriction in the movement of the neck, closing of mouth, difficulty in chewing food and drinking liquids, and rolling of saliva from the angle of mouth, and difficulty in speech due to difficulty in closing the mouth.
Okay, so this is before you go on to the general examination.
Sure.
I would. Hello.
Yes, sir.
Yeah. Before you go on to the general examination, see, I would like to suggest something to you. So, what was your chief complaints? Can you go back to your slide of chief complaints? Yeah, you said there is restriction of neck movements for 8 months and difficulty in closing the mouth for 6 months. I think, see, when a patient it's not like the other cases of general surgery that you present, right? Here, by the appearance of the patient, it's obvious that the patient is having a burn, post-burn contracture or
Yes, sir.
post-burn.
Yes, sir. Yes, yes.
So it means for the chief complaints, you need to state that from the very beginning that the patient has got a flame burns about 8 months ago, following which she developed restriction of leg movement. So I think the mention of burn should be in the chief complaint itself. It's not that, as you have mentioned in the history of present illness, but as far as this type of patient is concerned, I think that should be mentioned in the chief complaint. Right. Now, rest, Nick, go to the next slide. Okay, so this is obvious. Means you have correctly depicted about this thing, and one thing what I feel should be mentioned is when she is having flame burns in the chest and the face, right?
So,
Now, any difficulty in respiratory means is the patient having any respiratory difficulty or not? I think line or two mentioning that should also be included in the history of present illness, right? Because
okay,
facial burns are easily associated with inhalation injuries also, right?
yes,
So I think
sir.
sentence or two regarding that would have made this history more attractive. Right now, go to the family history. Okay, what is the significance? Why have we mentioned about family history? Do you feel that this is a congenital disease or
No,
this is
sir.
a
No, sir. No,
hereditary
sir.
disease
No, sir.
which
No,
will
sir.
occur in families?
No, sir.
Ah, so these are the things which you should take. It's not a what do I say? It's not a imprint that everything should fit into everything. So there are certain things which you should not, which does not hold any significance for certain group of patients. So family history, yes, family history may be important. Family history may be important in the sense that if the patient has got a history of, I mean, sometimes we find burn patients who are mentally disturbed, right?
Sir.
So there can be a link to that, but though that is a very distant dream, but still it can correlate it with that. But more or less, mota moti taur pe ye family history does not have any significance as far as burn injuries are concerned.
Sir.
Okay.
Sir.
Okay. So that was treatment history. Now she was treated with where was she treated?
Sir, in the hospital, sir.
Which
She
hospital?
was,
Which
sir, government hospital, sir.
Yeah. So see, treatment history is very important in this case. So you need to say that following burn injuries, she was treated at a government hospitals by regular dressing, antibiotics, and etc. And then you should mention whether she was advised any splint to be worn during this period. Number one. Number two, did she undergo any physiotherapy?
Yes, sir.
So these two things are very important in the treatment history. Okay, and now another thing is, as she was treated there, I think there should have been a mention about the percentage of burns that the patient has suffered. Was there any
Okay.
mention in the discharge ticket about the percentage of burns? Hello?
Yes, sir.
Yeah, is there any mention about the percentage of burns that the patient had sustained?
No, sir.
Yeah, so that is also important. Okay, the percentage of burns and the area of the burn. Right, and
Sir,
how
should
long?
we mention about the percentage of burn in the history itself, or
No, this is not an acute burn injury,
uh-huh.
isn't it? This is a follow-up of a burn.
Yes, sir. Yes, sir.
So you should means she has already been treated for that.
Yes, sir.
So
Yes, sir.
you never know. You cannot. Can you measure percentage of burn now? It's quite difficult, isn't it? We measure
Yes,
it
sir.
at the time of the accident.
Yes, sir. Yes, sir. Yes, sir.
So that is important. So that is what I am telling you about.
Okay, sir.
Got my point?
Yes, sir.
Okay, so that is also important. And following burns, we all know that burns wound heal by scar formation, right? So
Sir.
what you mentioned means what you need to mention is from the history itself means where are these scars present? Is it present in the head and neck area also, or she has got scars in other areas of the body also? So a brief mention about these things would have made this history much more apt or appropriate, right?
Sir.
Okay. Move on to the examination part.
Sir, examination, general survey. In general survey, her nutrition is poor. Otherwise, general survey was essentially normal. So in local examination, she was examined after taking proper consent in a well-lit room with proper exposure and in presence of a female attendant. There is a thick scar tissue involving the lower face from the angle of mandible of right side to the angle of mandible of the left side, anterior part of the neck and upper part of the chest. The neck is slightly flexed and she is unable to extend or rotate her neck. The lower lip is everted and there is gross contracture of the scar tissue. She cannot oppose her lips and there is constant drooling of saliva from the angle of the mouth. So there were no scar, burn, injury or scar in other parts of the body.
So this completes your examination.
Local examination, sir. Yes.
Now, is it complete? Is your examination part complete, or you need to say more?
Mm.
Do you have anything else in the examination part?
I don't know, sir.
Now, what is your next slide?
So systemic examination.
Okay, you continue then. Yes, you continue.
Okay,
This
sir.
is complete. Systemic examination is complete. Na?
Yes, sir.
And what is
Local
your next
examination is complete, sir. Systemic examination, sir. Systemic examination was also normal. Like.
Okay.
Next slide, please.
Okay. No. This is what I want to say. See, your examination for a star is quite insufficient. Right. Go back to this thing. It's not that easy, right? Post-bond contracture is not that easy that you can finish it off. And there are so many things. Like for an examination, you have inspection, palpation. So these, the movements, everything needs to be described. Right. So you have a general survey. You have done about nutrition. You did essentially, otherwise general survey is essentially normal. This I can write down. But as a student, you need to write down everything in details. It cannot, there can be no shortcut to this thing. So everything needs to be addressed, right?
Sure.
This is
Sure.
first. Thing is, local examination, you have to divide the local examination into 2 or 3 parts. Like, first is, you need to describe the scars. You need, because all the scars are not of the same type, right? So you need to describe the scars, where are these scars present? Number 1. Number 2 is, how are these scars? Where is the scar a single scar or there are radiating scars? And whether the scars are associated with any other complications. What can occur in the scars of a patient with burns?
Sir,
what are the complications
sir, post-burn, it might be associated with carcinoma, sir, margolin ulcer.
So ulceration.
Yes, sir.
So that needs to be mentioned. So, and are the scars, these are unhealthy scars, isn't it?
Yes,
But
sir.
you find there are certain sites in the neck where the scars might not be that much unhealthy. It may be supple also.
Sir.
So those things means for a scar to mention, you need to mention the site, you need to mention the extent, you need to mention whether it is healthy or unhealthy, you need to mention whether the scars appear as bands, you need to mention whether they are radiating scars, okay, and you need to mention whether the scar blanches on pressure or not, whether there is itching or not, whether the scar has transgressed the boundaries of the burn. That has to be mentioned. What are the different types of means following a burn injury? If you have a scar, what is the natural history of the scar formation? Means what are the different types of scars that can form out of burn injury? So So it can be an essentially a normal scar, number one. Okay.
Yes. Yes,
Number
sir.
two, it could be a hypertrophic scar.
Yes, sir.
It could be a keloid.
Yes, sir.
It could be a scar associated with an
Circumferential
ulcer.
scar.
It could be a Marjolin's ulcer.
So,
So these are the various types of scars. So do you feel that the scar is same in all parts of the neck?
no, sir.
No. So that is why it's very important that you need to describe these scars in detail. Okay. Now this is one aspect. Then come to the next aspect. Next aspect is symmetry. Right. So it is a facial burn.
Sure.
So there is an asymmetry.
Yes, sir.
As you mentioned, there is atropion of the lower lip.
Yes, sir.
Right. And if you, I haven't seen the picture, but to my feeling, gut feeling is that there could be that the angle of the mouth, it might have been shifted a bit downwards, that have stretched the ala of the nose also.
So,
Okay, so it means that area should be described very nicely. Right. So symmetrical aspect means that the normal shape of the neck that is lost, the normal contours of the neck that is lost. At the supraclavicular force are visible.
Sure.
Okay. So and because the chest is also involved, you said. So you
Sure.
need to describe the chest also. So this is another aspect. Right. Third is
Sure.
what you need to mention in details is about the movements, because this is very important. For any post-burn contraction, the range of movement that the patient has at the joints that are adjacent to the scars is very important, because when we are treating, if the joints are also involved and there is no movement in the joint, then it's a futile attempt to have any treatment for those scars. So neck movements, you said that there is difficulty in rotation of the neck,
so
isn't it?
extension and rotation of the neck, sir.
Extension and rotation. So is it due to the scar itself, or is it due to the neck, means the joints in the neck, or the cervical joints that are present in the neck? Is it due to that?
So it is because of the contracture of the scar, sir, which has limited the movement, sir.
Okay. So you need to mention about the movements in the neck. If there is limitation in extension, how much limitation is that? That has to be told in terms of degrees, right? How much extension, how much flexion? Okay, and that is very important to grade them according to ASA criteria, because for treatment, the patient needs to be anesthetized, isn't it?
Yes, sir.
So that is also important, and you need to mention about the oral hygiene of the patient. Okay, so these things are lacking in this history, which I feel is very important. A simple mere presentation like this won't suffice for a post-burn contracture, because it's so much important is related to all these things. Okay, got my point. So
Yes, sir.
he does not have any other burns in any other part of the body, right?
No, sir. No, sir.
Okay, axillas are free.
Yes, sir.
Okay, means the movement of the arms, abduction, adduction, flexion, extension.
Complete range of motion.
Okay. So only problem is she cannot close the mouth, number one. Number two is she cannot extend the neck.
Yes, sir.
Okay. And because of all these things, he is having some difficulty in both speed as well as speaking. Okay. So what is your summary then? Now summarize the whole thing.
So this 24-year-old female sustained stove flame burn injury 1 year back. So it involves the lower face, neck, and upper chest. She was admitted in a government hospital and was treated with intravenous fluid, antibiotic, and regular dressing. So I did not take the history of whether she took any physiotherapy.
Okay, what means I told you the
Achha.
points that
Yes,
are
yes,
lacking in
yes,
your
yes,
report.
yes, yes. The wound took about 4 months to heal completely and healed by scarring. After healing, she noticed that the scar tissues were getting thick and gradually, which led to progressive restriction in movements of the neck. She complained of difficulty in closing the mouth for last 6 months, difficulty in chewing food and drinking liquids, and drooping of saliva from angle of the mouth, difficulty in speech due to difficulty in closing the mouth. On examination, the nutrition is poor. There is a thick scar tissue involving the lower face from the angle of mandible of right side to the angle of mandible of the left side, anterior part of the chest, and anterior part of the neck and upper part of the chest. The neck is slightly flexed and she is unable to extend or rotate her neck. The lower lip is everted and there is gross contracture of scar tissue. She cannot oppose her lips and there is constant drooling of saliva from the angle of the mouth. The systemic examination is not.
Okay. So, what is your diagnosis then?
Sir, this is a case of post-burn contracture involving the face, neck, and chest. Upper
No,
chest.
another thing is you should mention about the duration because duration is very important.
So,
Because why I say duration is important because these scars are different stages of aging.
yes,
So
sir.
that is why the duration of this thing, the burn injury is very important. Okay. Okay. Now tell me, what type of burn do you feel this patient has been suffering from? Means what degree of burn?
Sir, third degree of burn on a deep burns.
Yeah. So this patient might have been suffering from a deep burn
Deep burn injury, sir.
because deep burn usually leads to
Scar
contraction.
formation. Sir.
Yeah. So now, how do you plan to manage this patient?
Sir, I'm planning for the surgical release of the contracture.
No, you won't investigate.
Sir, I'll do the pre-op investigations required.
What investigation? That is what I want to know.
Sir,
Before you, okay, you are planning. What is your plan? Okay, tell me your plan first. What were you telling? Plan?
sir, I'll plan for surgical. Sir, I plan for surgery, a release of the contracture, followed by sir physiotherapy, followed by skin grafting and physiotherapy.
Okay, so that is your plan.
Sir,
Means release of contracture followed by skin
skin
grafting
grafting.
and physiotherapy.
Sure.
Okay, very good. So now tell me, how will you prepare this patient for surgery?
Sir, I'll do the routine investigations. So
What do you mean
hemoglobin,
by routine investigation?
sir, hemoglobin
No,
total
no.
count.
Well, first, see, this is a common word I hear from everyone. Routine. See, in medicine, there is nothing known as no routine. Like class routine, you have first class surgery, second class medicine. There is no routine. So every patient is a specific patient. There are certain baseline investigations which need to be done.
So
So
baseline.
try to avoid this routine word, right? So you say,
Sure.
I will do the baseline investigation.
Sir,
Okay. What investigations will you?
so in bloods, I'll do blood for hemoglobin, total count, differential count, platelet, sir, urea, creatinine, the electrolytes, then coagulation profile. Then sir, for operation, I'll do serology test also. Apart from that, sir, I'll do chest X-ray, ECG. Uh, then, sir, I'll ask for a pre-anesthetic checkup of the patient. If the
First,
patient,
means wait. So you have done a baseline hematology examination.
sir,
You have done
ECG,
a chest X-ray
chest
and an
X-ray.
ECG.
Yeah.
So do you feel that this is all okay? Means, are you satisfied with only these investigations, or you need to do more? Do you need to do an X-ray of the neck?
Uh,
Is it required or not? Because you said that there is restriction of movement of the neck, isn't it? Both rotation and extension and flexion.
Yes, sir.
So there could be some pathology in the cervical vertebra also.
Yes, 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 yes.
So minimum that you can do is you can do a chest means X-ray of the neck. If you find that the X-ray of the neck is normal, then it's satisfied that no, okay, I do not need to do any further investigation. Okay.
Sure.
Now I said the patient could have had a inhalation injury, right?
Yes,
Do
yes,
you
sir.
need to do a pulmonary function test?
Yes, a pulmonary function. I'll do a pulmonary function.
So that is also important. So apart from the baseline investigation, the minimum investigations that you can do is you can do an X-ray of the cervical spine. You have to do a pulmonary function test.
Sure.
Okay. And then after suppose these tests are done, you send the patient for PAC. So in PAC, what do you expect?
Sir, I expect difficult intubation.
No, you are not going to intubate.
No, sir.
So the PAC is very important because they will grade the patient based on ASA criteria, whether it is grade 1, grade 2, grade 3. And you would, means for you, it is important that for the post-operative period, how stormy the post-operative period would be, that will give you an idea.
Sure.
Right. So that is important. Now, do you need to do anything else before you start surgery? Or you go in for surgery? Means, is there any role of pre-operative physiotherapy?
Sir, all the scars, as all the scars are not of same age, so physiotherapy might help in
Yeah. So
delaying the progression.
Because the scar is only 4 months old, so we can try physiotherapy so that we can limit the extent of the surgery. Okay. So the pre-operative physiotherapy, apart from the neck, chest physiotherapy is also important.
Yes, sir.
So these two physiotherapies are quite important. Okay. Then what will you do? Suppose you have taken up the patient for surgery, then how will you release the, you don't have any pictures. Huh? Have you had a picture? Then you could, for post-burn contracture, whenever you present, pictures are very important because sitting right here and only seeing the description, it is very difficult because there are too many aspects which are involved.
Actually, what about intubation? Dr. Dey?
Yeah.
What about anesthesia and intubation?
How will you means ask the anesthetist to intubate your patient?
Sir, as I'll be performing a surgery over the neck area, so I'll ask the anesthetist to put in a corrugated endotracheal tube.
What
Or if it is not.
What tube? What tube?
Is it a challenge? Is it a challenge for anesthetist to anesthetize such patient?
Yes, sir. Yes, sir.
Why? And what is the alternative?
Sir, because the neck is contracted, so the anesthetist will not, it will be difficult for them to extend the neck of the patient because of the contracture. Sir, alternative is a tracheostomy and intubation.
But you have some other facility in the theater?
Yes, sir. Fiber optic laryngoscopy and
yes.
that will.
Most of the time they do fiber laryngoscopy and intubation only. In rare circumstances, he might need to do a tracheostomy. Otherwise, we should have facility for fiber optic intubation. Carry on. Okay, carry on.
Okay, then suppose now will you do means apart from fiber optic Fiber optic is required because without this kind of contracture, if you have, without a fiber optic laryngoscope or a fiber optic endoscope, you cannot put in a endotracheal. It's very difficult. Will you do a nasal or an oral intubation? Huh? What would you opt for, nasal or an oral?
Preferably, I'll do a oral intubation, sir.
Why?
I'm not sure, sir. I'm not sure, sir.
No, the scar has involved the neck and lips are also involved. So
Yes.
you need to take care of that. So for that you need to operate in the area near the lips also. You need to release some scars here also. So
Yes,
if
sir.
you have an oral intubation, that will be very difficult for you, isn't it? So preferably a nasal intubation with a fiber optic scope is what is required in this case. Okay. So what will you do? Means you have said that there is a scar which extends from the angle of the mouth on one side to the other side.
Yes, sir. Involving the neck and upper part of the chest. Contracture is there.
So how do you intend to release that?
Sir, I'll.
Would you need to
Sir,
excise the scar?
I'll release the contract. I'll release the scar at the maximum contracture point. Then, sir, I'll try to extend the neck as far as possible. I'll put in a graft there, sir. A split thickness skin grafting, and I'll splint the graft, sir.
So you will put in a split. Means do you need to excise part? Because you said
Yes, sir. Yes,
there's
sir.
a
Yes,
thick
sir. I'll
band of
excise the
scar
graft.
which is thin, isn't it?
Yes, sir.
From where will you take the skin?
The anterolateral aspect of the thigh.
Anterolateral aspect of the thigh. Okay, suppose this is a face area. Now, if you put in a skin graft, aesthetically, do you feel it will be good? Because you find that this is a female patient, isn't it?
Yes.
Okay. Had this been a male patient, then the lateral part of the face will have beard, and the central part where you have put in the graft that won't have beard, isn't it? So there will be patchy areas of beard in that patient. So that would be very distressing for the patient also, isn't it? This is not very important in the face, but for other parts of the body, hair bearing area, especially in the axilla, we need to take care of this, right? For the face, there is no other option excepting for putting a split thickness skin graft. Okay. Now, suppose the patient has got a, means you said the patient can have margolin ulcer, isn't it?
Yeah.
Huh?
Yes, sir.
What is margolin ulcer?
The margolin ulcer is a development of squamous cell carcinoma over a long-standing scar, or
Does it metastasize?
sir, rarely, sir.
Huh?
Rarely.
Really? Okay, suppose the patient, you have an ulcerated area over there. So what will you do? Huh?
If the ulcerated area is small, I will perform a excisional biopsy using a 1 to 2 centimeter margin.
So it depends upon the size of the ulcer. First, you need to, because margolin ulcer has got typical shape, isn't it? So from the shape itself, you can make out that whether it is a malignancy which has occurred or is it a scar which is there. Because what happens is in post-band contracture, these ulcerated areas, they tend to heal and develop, because with each movement, the scar tends to fracture, right? And then you will develop an ulcer. Then it heals again, then it again fractures. Right. And do you need to, while doing surgery, do you need to take any extra precaution?
Postoperatively, I'll split the neck to avoid contracture of the
Huh?
graft. Splinting and physiotherapy postoperatively, sir.
No, during the operation. During the operation, do you need to take any extra precaution? See, this is a head and neck region, so there are many vital structures. Sometimes, while doing simple release, I think that won't suffice. So you need to give an aesthetic look. So to give an aesthetic look, I feel you should remove the scar and then place a graft. So beneath the scar, there are many vital structures, and as because there is burns, these structures may be adherent to the scar. So while you do that, you need to be very careful. Number one. Number two is you need to have adequate blood in hand because they tend to bleed too much while you are doing a scar excision. Okay, and right, you have said you would like to put in a split thickness skin graft, and then you would like to apply a splint, and then post-operatively you would like to give a physiotherapy. Right?
Sir.
Okay. Mahunda, I'm complete now.
How can you prevent such contracture?
Sir, I can prevent such contracture while treating the patient when she comes with burn injury at that point.
You said patient has flame burn, and the wound has healed in about 4 months' time.
Yes,
so how could have done it differently?
But I could have just, if possible, I would have just removed the burn area tangentially and put in a graft at the same time, surgically. Or if a medical treatment, then I would have aggressively splinted the neck and advised her for physiotherapy.
So one concept, in case of deep burns, one concept now is do early excision and grafting.
Yes.
And then the most important is post-op splinting and physiotherapy. Okay.
Yes, sir.
So these are the way you can avoid such, because this patient has deep burns, is flame burn, is likely to have a deep burn, and this will heal always by scarring. Okay, I think you can pass on the second case. Dr. Praditosh.
Yes, sir. Sir, my second case is a submandibular gland carcinoma. Patient particular with age, 50 years of age, residing in Ultadanga and government employee by occupation. He presented with a chief complaint of swelling below the left jaw for last 6 months and pain over the swelling for last 3 months. History of present illness. My patient was apparently well 6 months back when he noticed a small swelling below his left jaw while bathing. Initially, it was small in size, around 2 centimeter into 2 centimeter, but has grown rapidly to attain the present size. He also complains of dull, aching, constant pain over the swelling for the last 3 months. The pain has no aggravating factors and gets relieved with medications. There is no radiation of pain. No history of associated fever, no history of associated engorgement of the swelling during meals and decrease of the swelling in between the meals. Next slide, please. No history of pus discharge from the swelling, no history of chronic cough, no history of significant weight loss, no history of decreased appetite, no history of any other swelling in the oral cavity or any other swelling in the neck. Past history, the patient is non-hypertensive, non-diabetic, no features suggestive of hypo or hyperthyroidism, no history of irradiation of head and neck region in the past, no history of previous surgeries, no features suggestive of tuberculosis in the past. Personal history, he is a known chronic smoker, has been smoking for past 20 years with an average of 200 packs per year. He also has a history of chronic alcohol intake for last 20 years, taking around 300 ml of locally made alcohol per day. Take mixed diet, sleep, appetite, bowel, bladder habits are normal. Socioeconomic status, average income. Family history, no history of similar event in any other family members in the past. Treatment history, he's not on any regular medication, takes painkiller occasionally for the pain over the swelling. No known allergy to any medications. Summary, sir, my patient was apparently well 6 months back when he noticed a small swelling below his left jaw while bathing. Initially, it was small in size, around 2 centimeter into 2 centimeter, but has grown rapidly to attain the present size. He also complains of dull aching, constant pain over the swelling for last 3 months, which has no aggravating factor and gets relieved with medications. There is no radiation of pain, no history of fever, discharge, chronic cough, significant weight loss, no history of change in size with meals.
Okay, so this is the history of the patient, right? Now you say that there is a swelling which is located just below the left jaw.
Yes, sir.
What do you mean by left jaw?
Sir, that is what the patient told me.
So the
Actually,
patient
it is
told you
located
that
in the angle of the mandible, sir, below the angle of the mandible.
so why if I say it's in the upper part of the neck, am I right or wrong?
Yes, sir, you're right.
Means I feel that when you present a thyroid swelling, so you say there's a swelling in the neck. So it's jaw means it's over the mandible, right? So
Yes.
I think it's better to describe because see means grossly speaking, when you go proceed further, you will come to know that it's not actually the swelling which is obvious there is in part of the neck, isn't it? Not in the jaw. So I think a better description would be in relation to neck rather than mandible, rather than the jaw, telling it as jaw. So in the neck we have different triangles, isn't it? So it is that swelling is a part of one of the triangles of the neck. So it's better. Means I think anatomically it is better to say that it is in the upper part of the neck. The patient will say definitely say that it's below the left jaw, but I think it means the terminology wise, if you say if it is in the upper part of the neck, that makes more sense. Okay. So you said that there is a swelling there and it was present since the last 6 months and it has grown since last 6 months. It's the growth has been increased and to attain its present size, and it is associated with pain.
Dull aching pain, sir. Yes, sir. For last
Dull
3
aching
months.
pain. Dull aching pain where?
Over the swelling, sir.
Over the swelling. So there is no history of any radiating pain.
No, sir.
He does not have any difficulty in the speaking or eating. No difficulty.
No, sir.
Okay. Chewing also there is no difficulty.
No, sir.
Okay. There is a history of smoking and alcoholism.
Yes, sir.
So there are no other obvious swelling. Means he does not complain of any other swelling in the neck also.
No, sir.
Okay. Proceed.
So general survey, my patient is conscious, alert, cooperative, BMI of 22.5 kg per meter square. ECOG score is 0. Pulse is 80 beats per minute. Measured in right hand radial artery, good volume, rhythmic, no radial, radiofemoral delay. Arterial wall not palpable. BP is 128 by 80 millimeter of mercury, measured in right arm with patient in supine position. Is afebrile, respiratory rate of 14 per minute. No pallor, sinuses, icterus, clubbing or edema. Hydration is good, well nourished. No generalized lymphadenopathy, neck veins not engorged. Sir, local examination. Patient was examined after taking proper informed consent in a well-lit room with exposure up to the mid-chest level and maintaining the privacy of the patient. Inspection, there is a swelling in the submandibular region in the area of the digastric triangle and is around 5 centimeter to 4 centimeter in size, globular in shape. Surface is irregular, margin well defined, free from skin, no other swelling in other part of the neck. The skin over the swelling appears to be normal. There is no swelling or redness or discharge along the course of the submandibular duct opening, no other intraoral swelling seen. On palpation, inspectory findings are confirmed. The swelling is not non-tender. Temperature over the swelling is not raised. It is hard in feel, free from skin and underlying structures, bidigitally palpable. Neck nodes are not enlarged. There is no stone palpable in the submandibular duct when palpated intraorally. So systemic examination is normal.
So that was from the history, right? So examination, you said that there is a swelling in the submandibular region.
In the area of the digastric
triangle. So what is a digastric triangle?
So digastric triangle is an area bounded by the anterior belly of digastric muscle, posterior belly of the digastric muscle, and the mandible.
And what is submandibular fossa?
Sir, I don't know, sir.
So thyroid is present in a thyroid fossa. The submandibular gland is present in the submandibular fossa. So submandibular fossa is a place where the submandibular gland is present, and it is present in the anterior part of the digastric triangle. So it is bounded externally by the skin, then you have the platysma, and then the investigator cervical fossa, when it comes up from the neck, at the level of the anterior border of the submandibular gland, it splits into two. So one part goes and gets attached to the mylohyoid line just below the mandible. The other part is continuous above the submandibular gland. So the anterior part of the fossa is blind, but the posterior part of the fossa is open, like a thyroid gland. So the submandibular gland, if it enlarges, it can enlarge in the posterior direction. It cannot grow in the anterior direction, right? And whenever palpable, the superficial part is more palpable than the tissue. So that is what is submandibular fossa. Okay, so you need to know the anatomy of the submandibular fossa in case of submandibular gland swelling. Right. So how do you say that it's a? First of all, tell me, why do you say it's a submandibular gland?
Sir, it's a located in the.
Hello?
The voice is not clear, sir.
I think there is some noise. Someone is teaching me. Yes. Yes.
Hello?
Paritos, continue.
Yes, sir. Yes, sir.
Yeah.
Sir, the swelling is in the digastric triangle. Sir, it is bidigitally palpable.
Okay. Why is it not a lymph node? It could be a submandibular lymph node also, because submandibular lymph node.
Yes, submandibular lymph node, it can be a submandibular lymph node, but submandibular lymph node is not bidigitally palpable.
Good. So submandibular lymph nodes are not bidigitally palpable. Right. So it's and how do if I say that this gland is situated in the digastric triangle, you said, and what is the feel of the gland?
They're hard in feel, sir.
Hard in consistency. So it's a palpable growth from outside and from inside also.
Yes, sir.
Where did you search for the opening of the submandibular duct?
The opening of the submandibular duct, it opens in just lateral to the So frenulum lingually, on either side of the frenulum lingually, sir, it opens at the.
Okay. So did you check for the neck nodes?
Yes, sir. Neck nodes were not palpable.
No. It was a single swelling, isn't it?
Yes, sir.
So along with the swelling, were there any discrete swellings which were palpable over that swelling?
No, sir.
No. Okay. So you said no stones were palpable.
Yeah.
Why is it not a stone which you palpate? Why is it not a whole means stone which is palpable? Means it's a hard stone which is present there and it is palpable.
Sir, because with stone, sir, the patient will have complaint of difficulty in chewing, increase in size while chewing, increase in pain.
So that history would have been different, isn't it?
Yes, sir. Sure.
Submandibular stones are common in which of the salivary glands?
The stones are more common in submandibular salivary glands.
Why?
Sir, because the secretions of submandibular gland are more viscous. Sir, the chances of stasis is more because the submandibular duct, the Wharton's duct, is located at a level a little higher than the level of the submandibular gland. So these two factors
And
precipitate
also
for.
the submandibular gland is a gland which produces the highest amount of saliva compared to the other gland. So most of means roughly 50 to 60% of the saliva is produced by the submandibular gland, and then comes the parotid, and then comes the other submucous glands which are present. Okay, so that is not a stone.
No,
Right.
sir.
So we have a swelling which has increased in size very rapidly with a localized pain. So did you examine for the any cranial nerves?
Sir, I examined for sir, orbicularis, oris, platysma, whether they are
cranial nerves. Tell me about.
No. What about tongue? What about tongue?
Yes, sir. There was no deviation of tongue, sir.
Do you expect any tongue movement alteration in submandibular gland carcinoma?
Sir, if it involves the hypoglossal nerve, then
Yes.
there might be deviation of tongue, sir.
Which side?
Can't it involve the lingual nerve?
Yes, sir. It can involve the lingual nerve, sir.
So lingual nerve can also be involved.
Yes, sir.
Facial nerve also can be involved.
Yes, sir. Yes, sir.
Marginal mandibular nerve can also be involved.
Cervical
So,
branch.
you need to examine both the fifth cranial nerve, the seventh, and the 12th, right? These three cranial nerves you need to involve, and you need to, in the summary also, you need to, because you know why the importance is that sometimes the only clue to a submandibular gland carcinoma is involvement of this nerve. So the patients, they usually present with certain asymmetry in the face, and then while investigations, we recognize that these patients are having submandibular gland carcinoma. So that is why
Yes, sir.
examination of the cranial nerves are so important in case of submandibular gland swelling. Okay.
Yeah.
Okay. So what is your? So this was a summary. Okay. You did not tell me again about the summary. Tell me what is your diagnosis.
Sir, my diagnosis is this is a case of submandibular gland carcinoma of the left side with no lymph node enlargement.
Okay. What are the differential diagnosis?
The differential diagnosis is sir, neck nodes enlargement because of either a tuberculosis or some other carcinoma, sir, lymphoma. Sir, then sir, the mandibular gland sialadenitis, which is not evident by the history and examinations.
Okay. So if I say that this is not a submandibular gland, this is an extension from the parotid gland. How can you deny my charge?
The parotid gland swelling will be covering the retromandibular area. There will be retromandibular fullness. The
No, it's
ear
not always
lobules
that
will
you have a retromandibular fullness. Only if the tail of the parotid or the interior border of the parotid is involved, then there is a fullness there. It's not obvious in all cases. There's an important anatomical landmark which divides the parotid from the submandibular gland. So that is stylomandibular ligament, right? So whenever there is a parotid, means if it is a submandibular gland, it won't go above the level of the mandible. And similarly, a parotid gland, when it enlarges, it can be big, but usually it does not encroach the submandibular fossa. Okay, now you say it's a malignancy, right, of the parotid gland. Why do you say it's a malignant submandibular gland?
Sir, age of the patient is 50 years old, male patient. From history, sir, there is rapid enlargement of the swelling within 6 months. Then, sir, background, he is a chronic alcoholic, chronic smoker. Sir,
What relation does alcohol and smoking have with parotid malignancy?
sir, chronic alcoholism has been attributed to development of submandibular gland carcinoma.
No, there is no.
I don't means
There is no direct correlation between smoking and alcohol with salivary carcinomas. It's more of carcinoma of the floor of the mouth or oral carcinomas.
yes, yes. What is the primary unit of a means any salivary gland? What is the primary unit? Like breast, you have TDLUs, right? So what is the primary unit of a salivary gland from which these malignancies usually arise?
Sir, I did not get your question, sir.
What is the primary, like in breast, you have heard about TDLUs, terminal duct lobular units. Have you heard of that?
No, sir.
No. Okay, means I want to ask you, these salivary glands are made up of what? These are made up of ducts and acini.
Yes, sir.
Right. So these ducts and acini, they have, like the breast, they have myoepithelial cells which usually surround these acini. Right. And these acini, they secrete the saliva, and then the myoepithelial cells, they contract, and this causes expulsion of the saliva from the gland. Now this unit, that is myoepithelial cells and the acini with the ducts, one single is known as a salivon, SALIVON, right? And it is primarily from this site where the malignancies of the salivary glands usually arise. Okay, so
Yes,
that is the area from where it arises. Now, of the salivary glands, which gland has the highest propensity to develop malignancy?
The minor salivary glands.
Minor salivary.
Then, sir, decreasing frequency, sir, submandibular gland, 50% of them are benign and 50% malignant. Then, sir, parotid gland, 80% are benign, 20% are malignant.
Very good. So 80% are benign, 20% are malignant. Now, what kind of malignancy? What is the commonest malignancy of the parotid?
Sir,
Nucleoepidermoid carcinoma. Right. And what is the commonest malignancy of the submandibular gland?
Pleomorphic.
Adenoid cystic carcinoma. Pleomorphic carcinoma is pleomorphic adenoma. That is not very much common in the submandibular. Adenoid cystic carcinoma is the commonest malignancy of the submandibular gland, whereas mucoepidermoid carcinoma is the commonest malignancy of the other salivary gland. Now, what is so special about adenoid cystic carcinoma?
Sir, don't know, sir.
It has got a
These are
perineal
more
square.
aggressive. These are more aggressive or same behavior.
Don't know, sir.
Administration are more aggressive and they have perineal invasion.
How does, can you tell me how does this perineal invasion occur? Is it the gland which involves the nerve, or it is the nerve which is attracted towards the gland?
Sir, sir, the growth in the gland might get invaded to the nerves because of the close relation of the nerve to the gland.
No, it's not that. These adenoid cystic carcinomas, they secrete one nerve growth factor, right? So the common malignancy in other parts of the body is that the malignancy, it grows and then it involves the nerves, isn't it? Here what happens is these cells, they secrete a nerve growth factor. And then the interesting fact is that the nerve is attracted towards that cell, means the growth. So if you see a histology, you will find that there is a nerve inside, and then you have a perineal sheath, and then you have the tumor cells which are present. Histologically, you find. And because of this perineal growth, these malignancies, they tend to present with neurological involvement before anything. Okay.
Sure.
Now, how will you investigate this patient?
Sir, I would like to confirm my diagnosis by doing FNAC from the swelling.
Okay. Then anything else?
Sir, I can do a CT also.
Why you can? You can or you should?
Sir, because it is not necessary in all the cases of
Which
a
cases is it
submandibular
necessary?
gland carcinoma if
Okay,
the
tell me
gland
the-
is deviated. The deep, sir.
Tell me which are the cases where you need to do a CT scan then?
Sir, when deep lobe is not clearly, all the margins are not clearly palpable, or the extent of the tumor is not clearly felt. In those cases, we'll need to know the extent of the tumor by doing a CT scan.
So, and CT scan of the, apart from CT scan of the neck, do you want to do CT scan of any other part of the body?
Sir,
You want to do a CT scan of the chest?
abdomen, CT scan of the abdomen to see
Abdomen.
if
Abdomen, why? Why abdomen?
sir, I'll look for metastasis.
Rarely
If
it
I want
occurs
to
in the abdomen. Abdominal metastasis is very, very rare.
yes, sir, very rare.
So, you need to do a CT chest, right? Because sometimes if there are recurrences, it occurs in the chest also. And metastasis is more common in the chest than in the abdomen.
Sir, just a question, sir.
Yes.
Sir, should we first do a chest X-ray, or we should directly go for a CT scan, or we should ask for a CT scan of the swelling neck and chest directly in one go? Because we are already, if we are doing CT scan of the swelling.
It is a routine for submandibular carcinoma.
We'll directly go for a chest CT, sir.
Yes, it means for these malignancies. See, mucoepidermoid carcinoma is the commonest. So that has a propensity to metastasize. Submandibular gland carcinoma, so these are have a very good prognosis because Rarely there is any lymph node metastasis. The others have lymph node metastasis, but submandibular carcinomas rarely have lymph node metastasis. So for other malignancies and for histology apart from adenoid cystic, which has got a propensity to metastasize, I feel you should go in for a chest CT prior to, means even if you do a chest X-ray, you need to do a chest CT because that will give you an extent as to whether there is any metastasis or not. Okay. Okay, then you have done a FNAC, you have done a investigation. So what will be your treatment?
Sir, I'll plan for excision of the submandibular gland as a whole.
What are the precautions you will take during excision?
Sir, I'll try I'll try avoiding the nerve injuries that can occur, like the submandibular branch of the facial nerve.
Submandibular branch of the facial nerve.
Submandibular.
Facial nerve, sir?
Marginal mandibular.
Marginal mandibular branch of facial nerve.
Okay.
Then, sir, the lingual nerve.
Where will you take care of the lingual nerve? At which part of the dissection?
Sir, after we have dissected the superficial gland, superficial part of the gland, lobe of the gland.
What do you mean by superficial part of the gland? What divides the gland into superficial and deep?
The mylohyoid muscle, sir.
Okay, very good. Then, once you have excised the superficial
after
part,
the
then
dissection, sir,
where do you find the lingual nerve?
Sir, after the dissection of the superficial nerve, when we go for the deep lobe of the submandibular gland, there we'll find the sublingual nerve.
So how is it lingual nerve involved with the lingual nerve is involved with which part of the submandibular gland? Or is it involved with part of the duct? It hooks the duct, right? So that is the reason when we have sialoadenitis or anything which is there in the duct, we don't go posteriorly.
Lingual nerve
First
is the
we palpate, and then over that palpating means if we can palpate, then we only put in an incision.
Yes, sir.
Okay. What other nerves you need to take care of?
The hypoglossal nerve.
Very good. So hypoglossal nerve you need to take care of. What are the are there any arteries which come in relation during in dissection?
Sir, arteries, sir, the facial arteries.
How many times do you have to ligate that? Or you can save that?
I did not get your question, sir. Please.
The facial artery comes in way, right?
Yeah, sir.
So you need to ligate that facial artery, right?
Yes, sir. Yes, sir.
How many times do you need to do that? Twice or once only?
Twice, sir.
Twice, right? Twice?
I don't know, sir.
Because it passes through the submandibular. So once you need to tie above, once you need to tie below.
Achha, sir.
Okay. Okay. So you need to take care of two nerves. You need to take care of one vessel which is present. Okay. So after you have excised the whole gland, now do you want to do anything else as far as treatment is concerned?
Yes, sir. I'll go for post-operative radiotherapy.
So you need to give radiotherapy also. Is there any role of monoclonal antibodies and targeted therapies in case of submandibular duct CA, submandibular gland carcinoma?
Sir, I don't know, sir.
Yeah, nowadays there is some. I think you can go through the books, but I have seen articles regarding this. So this is upcoming. So I think that you see it, it's there. There is some role. Okay. Okay, Mahanda, I'm done now. I think, Paritos,
Sir.
we have come to the end of it. It's already time's passed. Sir is there. I can't see sir now.
So I think Professor Saha has logged out. He's not.
Okay. Then thank you so much. Right.
Sir.
So
Thank you, sir.
I think we can end now.
Thank you, sir.
Okay. Thank you. Thank you so much.